The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD Warriors. I'm Tony Urbanek, and we're here for the next episode of TMD Demystified. Today, the topic is entitled Treating TMD Logically. Treating TMD Logically. Subtitle, Cause and Effect, and treating the cause rather than the symptom. This is a profound concept, at least as it applies to the treatment of TMD. As I've said many times in front of large audiences and several times on podcasts, I am surprised at the deeper I got into actually studying the symptoms in patients, coming directly from the patients, what has been considered the norm in treating temporomandibular joint problems throughout the United States, the only country I'm familiar with, and I assume the rest of the world to a greater or lesser degree. But the issue is to treat TMD logically, like the medical profession treats other problems, other diseases. For example, first thing that comes to my mind is if you treat tuberculosis, if a medical doctor runs into a patient and the diagnosis is made that they have tuberculosis, does the treatment plan just include treating the symptoms, or do they go after the cause? Of course, we know the cause of tuberculosis is an acid-fast bacillus, which is very susceptible to treatment with appropriate antibiotics and can wipe that acid-fast bacillus out and totally do away with tuberculosis. Or another good example currently in our world is the treatment of polio. As a very active Rotarian, Rotary International now is on the very edge of actually completing our program and doing away with polio throughout the world. Polio is obviously a virus, and there, to our knowledge, only one country in the world that still has any polio cases, and that's Pakistan, and they only have a handful of them. So as the polio vaccine being defined as an injection which totally eradicates the virus and doesn't allow it to replicate within the body at all, 100%. We have a vaccine against polio, and when everyone is vaccinated against polio, there will be no more polio on the planet. Now, you can treat the symptoms of polio by doing various supplemental care of the patient and assisting them in their symptoms. Like you can give supplemental care on someone with tuberculosis who has respiratory issues and other issues regarding the symptoms of tuberculosis to assist them with their symptoms, but the eradication and the actual treatment goes directly to the cause. All right, I made my point. Now, what I have seen since I delved deeply into this and 10 years ago quit doing temporomandibular joint surgery is that across the board, pretty much everyone in dentistry who is involved in one way or another treating temporomandibular joint disease symptoms are only treating symptoms and they're not treating the cause. It's stunning, actually, when it is obvious that the cause of all the symptoms is inflammation within the temporomandibular joint. So if you can treat the inflammation and eradicate it, which frankly, eradication of inflammation and chronic inflammation is a very hard thing to do, but decrease inflammation adequately so that it doesn't cause the symptoms, which is done quite directly by unloading the joint long enough to decrease inflammation within the joint, which decreases the symptoms. Now, I've said many times that, if you had a drug that totally decreased inflammation within a joint, that's all you'd have to do. And we know that nonsteroidals will do a very good job of decreasing inflammation within the body under many circumstances, and especially within joints for a short period of time. And it's also well known that anti-inflammatories, Motrin, Tylenol, or aspirin will have a very short-term effect, and within a few weeks of using them chronically, it will cause significant gastrointestinal upset, and you'll have more pain come from your stomach than you have come from your joints. So nonsteroidals aren't an effective treatment to decrease inflammation in the long term, but unloading the joint adequately using a proper tool and protocol will, and that's what we found. But let's go through this logically, or try to, regarding what is being done, and is it logical or illogical to use these efforts in treating the problem better known as TMD, actually TMJ, temporomandibular joint disorders. So what is, what are we trying to do? Are we trying to be effective, or are we just trying to throw things at the wall and see what happens? So let's talk, we talked about drugs, that's first on the list, drugs. Short-term effect, nonsteroidals work pretty well. Are there other drugs that are effective in treating TMD? I think I've seen just about all of them that are routinely used, which would include muscle relaxants and neuroleptics. I have seen psychiatric drugs. I have seen many cases of narcotics. I've seen patients addicted to narcotics because of chronic use of narcotics for temporomandibular joint disorders that were prescribed by various doctors, both dentists and physicians. Not good. But are you treating the cause? Are you just treating the symptoms of the pain? You're just treating the symptoms and you're not treating the cause. Now, the next on the list is Botox. Now, Botox is a very good treatment for paralyzing muscles and is used extensively for cosmetic reasons, and I have no issue with that if that's what you're using it for. But to paralyze a muscle or a muscle set for temporomandibular joint disorders is certainly treating a symptom. If you have trismus of the masseter muscle or the temporal muscle causing pain where the muscle attaches or inserts, then you'll have pain where that muscle does that, and you paralyze that muscle adequately. It won't pull on the bone, it will not stimulate the nociceptors, and that particular muscle, when stimulated by the central nervous system to go into trismus, tighten up, will not tighten up and will not pull on the bone, and for that particular area of the face or the neck or the shoulders, that will not occur and you will not have that pain, but it will not affect any of the other symptoms that are associated with temporomandibular joint disorders. And for one of many times to outline all of the symptoms that are seen, which would include headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper shoulder and arm pain, and upper back pain, not lower, arm, hand, finger tingling and numbness, and mandibular locking and inability to open of various kinds. Those are the chronic symptoms of TMD, and I rarely see patients with just one of those symptoms. In fact, patients will come in with their primary complaint of, well, I have headaches every morning. Every morning it hurts here, or every morning it hurts here, every morning it hurts here. But when you do a thorough history, the patient's eyes shoot open when you go through the litany of other symptoms. Have you had any of these other symptoms? And they will give you multiple hits on that list and say, I had no idea that those symptoms were coming from my jaw joint. And so what you're doing by using Botox is you are treating a particular muscle or set of muscles, but you're ignoring all the other symptoms because you have not treated the cause. You are just treating symptoms. It's not logical. It's not logical medically. Makes no sense. Trigger point injections, same thing. Yes, you can locally anesthetize what is commonly referred to as a trigger point. I'm not even sure that there is such a thing as a trigger point. There are areas of the muscle that get tight, they get knotty. You want to call that a trigger point, okay. But again, it is trismus of the muscle pulling on the bone. It hurts where the muscle pulls on the bone. If you inject a trigger point with local anesthetic, it will anesthetize that particular area for a short period of time. When the anesthetic wears off, you may get some temporary relief in that muscle or muscle set. But you're not treating the cause, and the inflammation continues to signal to the central nervous system then signals to the muscles, tighten up, and causing all of the other symptoms depending on the time that the patient has suffered inflammation, chronic inflammation within the joint. And it's an ongoing system that continues to occur, and you're only treating things symptomatically. Massage therapy, same thing. You're just treating a local set of circumstances having to do with the muscles, but you're ignoring all the other symptoms. And I can promise you that the vast majority, I mean, I would estimate at least 90% of the patients who have muscle trismus symptoms, headache, shoulder pain, neck pain, they have 90% of those or more of those patients will also have other symptoms that you're ignoring and that they're having constantly. All you have to do is ask them, do you have any other of these symptoms on this symptom list? So you're ignoring all those symptoms. It's illogical. Chiropractic, same thing. I have nothing negative to say about chiropractic. I've used chiropractic multiple times in my career to a successful extent, treating certain, back issues I've had, and very effective on treating muscular issues. And sometimes it would be temporary and sometimes it would be permanent, but only the muscle issues. Physical therapy, same thing. In physical therapy, the latest thing that I hear frequently is dry needling. And I think it has been shown that puncturing the skin, multiple dry needling into the muscles will have an effect on that muscle to apparently relax it. I think that's the theory behind it. Just like Botox, just like massage therapy, but you're not treating the cause, which is inflammation within the joint. When the joint becomes inflamed, it sends an autonomic signal to the central nervous system indicating the joint's inflamed. The autonomic central nervous system says, tighten up, and it will tighten up the muscles. of various areas trying not to move that joint. And that explains all of the symptoms of muscular, and then the middle symptoms of what I refer to as middle symptoms, because that's where they are on the list of tinnitus, subjective hearing loss, described by most patients as fullness in the ears, and vertigo, has everything to do with the inflammatory fluids dissecting into the inner ear from the glenoid fossa through the petrotympanic fissure, which is anatomically present and proven as a site that will allow access from the glenoid fossa into the inner ear, the petrotympanic fissure, which explains those three symptoms when inflammation gets into the inner ear, which our ENT colleagues are not aware of yet, for the most part. There are a few in Middle Tennessee. And that is a huge problem for ENT, because they shake their head, roll their eyes, and say, I can't help you. I don't know how to help you with those symptoms, for the most part. Surgery, I'm well qualified to talk about surgery on the temporomandibular joints, having performed over 2,000 surgeries over a period of 30 years, my first 30 years of my career, half of them open joint through an incision in front of the ear, and half of them through an arthroscope. And I can attest that both I and my colleagues who do surgery have found out that surgery is not the answer. Surgery is still being used within the spectrum of oral and maxillofacial surgery procedures. It is not done anywhere near as often. For the most part, all of my colleagues realized that surgery is not a long-term solution. It is the treatment of last resort. And what I have seen, based on 3,000 cases of my own, and also hundreds of cases performed by other doctors who use the urbanic device and protocol, unloading the joint long enough to decrease inflammation, and that the cases that would, in other hands, go directly to surgery can have alleviation of their symptoms long-term using the device and protocol. Device, quote, tool. It's a tool to use to unload the joint adequately to decrease chronic inflammation and ameliorate the symptoms. So surgery is definitely not the answer. And I think that maxillofacial surgery, even the American Association of Oral and Maxillofacial Surgeons have admitted in public that they have done a very poor job in treating temporomandibular joint problems. Comment to my general dental colleagues about mouth guards. I think on a previous episode, I commented about mouth guards being deployed for temporomandibular joint problems is really a misnomer. It's a misapplication of a service which does nothing more than cover the surface of the teeth and prevent damage to the teeth. That's what a mouth guard does, whether it be used as a mouth guard in athletics, or a mouth guard just to wear at night for bruxing. Very effective to limit damage to the surface of the teeth, but actually in almost all cases, wearing a mouth guard and being told that that's going to treat TMD symptoms will actually, in most cases, make it worse, because it just gives you something else to chew on and chew on through your posterior teeth And as we know, 90% of the loads on the temporomandibular joint or more are from the posterior occlusion. And so if you put a mouth guard in your mouth, whether soft or hard, and you just continue to brux, you're not going to unload the joint anymore with a mouth guard. So that's actually inappropriate treatment for temporomandibular joint problems. Totally inappropriate. And then there are other devices that can be used to unload the joint by increasing the distance between the posterior teeth, so that even though you're bruxing, you can't load the joint. The one that I see the most, hear about the most, is the NTI, and the NTI, I think effectively this occludes the posterior teeth. The problem with the NTI, although it has a good reputation and is effective in some cases, the problem with the NTI is you can't wear it long enough. You can't wear it 24/7. You can't speak with it in your mouth. You can't wear it during the day, and therefore it has limits on the effectiveness on cases because of it is time dependent. You can only wear it certain periods of time. But for the most part, these treatments, and I've outlined most of them, there may be some others I skipped or didn't think of, but using drugs, Botox, trigger point injections, massage therapy, chiropractic, physical therapy, surgery for sure, and mouth guards it's just not logical, because you're not treating the cause. Cause being inflammation, chronic inflammation within the temporomandibular joints. It is irrelevant when you look at x-rays, MRI, CT scans, or plain views, Panorex, how much damage is done to the joint. That is, you're not treating an x-ray. And again, in experience of myself and the other doctors in our network who use the Urbanic device and protocol, they find the same thing. It's irrelevant what the x-ray looks like. You're not treating the x-ray. And if there is damage seen on x-rays, or if you note a dislocated disc or a perforated disc on an MRI, it's all the same when you unload the joint. Inflammation will decrease. Now, you're not going to fix a perforated or dislocated disc necessarily. Actually, though, we do see the disc do routinely come back into a more normal position when chronic inflammation decreases, which increases the ability of the synovial fluid to lubricate. Synovial fluid under the influence of chronic inflammation is very sticky, and synovial fluid in its natural state is very fine lubrication. It's designed to be a lubricant in the body, synovial fluid. But under the influence of chronic inflammation is very sticky, which explains why the disc actually becomes dislocated under the chronic motion of the temporomandibular joint, and eventually it sticks and pulls the disc usually forward, and causes the well-known problems of various kinds of locking, open locks, partial and complete deviation of the mandible to the right or left on a dislocated disc, things like that. But again, it is irrelevant what the x-ray looks like, as long as you can decrease enough of the inflammation within the joint to decrease these symptoms. So you're treating the cause rather than the symptoms or the effect. So that's my presentation for today. I hope it makes sense to you. I consider it logical, and I would entertain any comments, suggestions, criticisms, no problem. You can contact me at Tony Urbanic at Tony Urbanic at tmjservices.net. And for those of you who are interested in using our technology and device and protocol and be licensed as a network provider for our patented and FDA approved device, I encourage you, because this is a huge problem, huge problem. The more I did it, the more I found that it is amazingly misdiagnosed, misdirected, mistreated to the point that the patients are absolutely frustrated going from doctor to doctor to doctor. And the number of cases, I mean, that we see is on a daily basis now is huge. And I'm seriously attempting to correct this, do my part, but I can't do it by myself. And I encourage doctors out there who want to do it for their patients, want to do it for the right reasons, to join our network and become successful at it, both from your patient's point of view and from your practice economic point of view. So you can contact myself, you can contact our director of marketing and education, Naomi, at naomi@tmjservices.net. Our website is www.tmjservices.net. And I look forward to hearing from any of you on for any reason at all. I am Tony Urbanic, and this is TMD Demystified.